Alrighty. So the questions, of course, are weighted to the afternoon speakers, but maybe we can, other people now realizing that we've got our morning speakers here, can write some more questions. Dr. Bushnell, how long does ludotherapy RRT treatment continue to work after the fourth treatment? What is the average time of stabilization before growth after ludotherapy RRT? Can you comment?
Well, you know, first of all, it's very variable, but the tumor's sort of on average 3, 4, 5 year. That's kind of an average recurrence after PRRT, if that's what you mean.
Dr. Chandras, did you want to comment on that, or just?
I think the answer would depend on how the tumor was growing before the PRRT. So as we saw, NETTER-2 study included some of the faster growing or grade 3 tumors. I would expect those patients to have lesser time after PRRT if the tumor continues to grow similar to what it was doing before. So I think a lot of the repeat PRRT trials or PRRT post trials are looking at least stability for a minimum of 6 months, at the very least 6 months after a PRRT to enroll in another type of PRRT. But I think there's some data for like a stability for at least a year, year and a half being like a better sign for going for another round of PRRT. So very variable.
All right, hold on to that microphone, Dr. Chandras. Karen. Are there clinical trials planned for high-grade, poorly differentiated tumors? Can you comment on that space?
Yes, there is one completed study that's awaiting results to be published on, which is looking at what we call a platinum-based chemotherapy compared to another drug regimen like the temozolomide-based chemotherapy. Now, you know, one thing about the neuroendocrine trials is, like I said, these high-grade, though we call them high-grade, it's hard to put them all in one bucket again. So that study did include some patients who had what we call grade 3 tumors, but some could have been what we now call well-differentiated grade 3 tumors, so kind of the better ones of the bad ones situation. So it's going to be a little hard to interpret the data when it becomes available with more details. Now, beyond that, are there high-grade for neuroendocrine carcinoma, again, which is basically the poorly differentiated studies. There are multiple clinical trials. This is probably a very high unmet need. There are some interesting clinical trials, that, especially one that we have at University of Iowa for high grade that's targeting. You should tell me to stop. You should tell me to stop when I'm ready to stop. Sorry. SCZ6 protein, which is like a target. Another one called delta-like ligand. There's another target. So these are some very interesting targets for high-grade neuroendocrine carcinomas. I think for the well-differentiated G3, we still would be using hopefully alpha therapies and PRRT as long as they have receptors along with the drug therapies. And the cabozantinib data that was presented also included some grade 3 well-differentiated neuroendocrine tumor. So.
Great, thank you. So I think the answer to that was yes. How long will it be before we have FDA approval for alpha particle?
FDA approval for alpha particles.
Mm-hmm.
Ooh, I'm going to say the first alpha agent that'll be approved is going to be in 2 years.
Good stuff. Optimistic guy.
More optimistic timeline, but
You think okay?
well, I mean, Action 1 is still enrolling, which will probably be the largest registrational trial, which is the actinium trial, and you know, there's been some delays, partly pandemic, partly supply chain issues. I don't know how much they are to enrollment. I don't think they're half enrolled yet. So that's basically, you know, we have to complete enrollment for the study, wait for some data to read out for interim analysis at least. So 2 years seems a little optimistic to me for FDA approval. Probably longer, I mean, few years.
FDA sometimes has a fast track. Are these
priority.
fast tracked? Does anybody know?
Yeah, I was going to make one comment because the Alphamedics phase 2 has completed accrual. So, so that data will come out, and it is sort of kind of getting fast-tracked. There was a question of whether or not they were going to forego the phase 3. I think they are going to move into a phase 3. So I think that, although that's a very, I think, important question if you want to take something off the shelf, which all of us would prefer to do, as opposed to being limited to different sites having trials availability, I think that between the actinium-225 phase 3 and the PB212 phase 3 at more sites, I think that your ability to get alpha particles with the data that is coming out showing an objective response rate that is quite impressive, I think you would still be able to consider getting it. It's just that none of us would be able to take it off the shelf and use it however we want. Meaning we wouldn't be limited to what the eligibility criteria.
Great, thank you. A question for, I guess, any of the clinicians. An interesting question. I assume a scan is a scan, but I'm always concerned whether it is being read by local doctors instead of a major specialist doctor. Is this a valid concern? I think there are two things there. One is the radiologist reading, and the question of, is a scan a scan? Anybody take that one?
The radiologist, the lowly radiologist during my day job, no. So a scan is not a scan is not a scan, as we know. So there are very important protocols that need to be run. So if you get a scan at some hospital and they don't do, for example, diffusion-weighted imaging, which is where we look at water, the shaking of water particles, it's very important for us, and that's usually the scan I look at first. And so many centers will not do that. So you have to just make sure you're going to a center. The other thing is you want to stick with the type of scan you're getting. So if you're going back and forth and getting an MR and then a CT, that can be really challenging. So you just want to make sure they have the appropriate protocol. If you're going to a place and you see the doctor and they say, oh yeah, that's a good scan, you can keep going to that place. It's not that there are not good places. It just has to be a place that has a scan that's good enough to get the information they need. A radiologist is not a radiologist is not a radiologist. So just like a surgeon is not a surgeon is not a surgeon, there are people that are very skilled in reading scans. So patients that undergo Y90, they'll read the post-scan as progression because the liver will swell and the tumors may look a little bigger, and that's not true. They're dead inside. They just look swollen because we've given them radiation. So I would just tread lightly if you're going to a big academic center to get your medical care and you're getting your imaging locally. I tell my patients, don't look at the read. Just don't. Forget about it. I never look at the read because it's going to be important that the person that's delivering the modality or the treatment knows about these pseudo-progression imaging. So just be very careful about where you get your imaging and know that, you know, if somebody's looked at it and that your tertiary care center doctors are saying that this is a fine scan, you can go to that center, that's fine, but no, they're not all the same, for sure.
Thank you, excellent. I'm going to crack off this one. Do folks with non-functional tumors need to avoid epinephrine? Yes. So epinephrine, we suggest to people that they don't get epinephrine when they get their dental Novocaine with epinephrine, because epinephrine can stimulate hormone secretion from these tumors. So the fact that a person hasn't had carcinoid syndrome or carcinoid crisis up to this is no guarantee that they couldn't have carcinoid crisis. Dr. Bushnell, or indeed Dr. Chandrika, because you were also talking about and indeed, Michael, you were also talking about where treatments come in the stage of therapy. So the question is, can you talk about the change in usage of PRT from an end-stage treatment to a first-line therapy? There really has been a change with availability.
Sure. Yeah. So it's. I think the kind of focus of the question is, you know, can PRRT be used a little bit earlier in the therapeutic chain? Is that sort of the idea? And I think that there are some real cogent reasons to think that's a better idea. First of all, we know that the radiation delivered to the tumor and to some extent the effectiveness of the radiation is better when the tumor is sort of smaller. So if you let it get too big, then the effectiveness, the likelihood, the probability of effectiveness is not as great. So we also know that if the total tumor burden is large compared to not large, and the exact cutoff isn't entirely clear to us, that the likelihood of response to either alpha or beta PRRT is going to be diminished. So there are other reasons as well to think about, and frankly, side effects. The side effect profile, I think, is at least the more short-term side effect. There is a little bit of a concern with, and Dr. Chandrika could talk about the myelodysplastic syndrome. It's rare, but it does occur. And then at least in some of our early thinking when I showed a slide with the alpha particles, there is some concern, particularly with the lead-212 agent, and there's a reason for that compared to the actinium, that the kidneys, we have to be a little bit more focused on the kidneys when we're thinking about using the alpha up front, so earlier on, for people who have a longer-term survival outlook. So, yeah, go ahead.
But I was actually going to ask a question on your behalf to the two of them. So you will meet forks in the road where the tumor is growing despite what it is we're doing. And it's usually going to be that the tumor's growing despite being on somatostatin receptor analog therapy. And so you get to this fork in the road, and now you're saying, well, based on this PET scan, is PRT a great option? Or you'd say, oh, based on the biopsy results, is chemo an option? And I think the emerging data that's making us a little nervous is that people that have gotten PRRT and then need chemotherapy tend to have worse bone marrow related side effects of the chemotherapy, and vice versa, although we can't identify which patients would be at highest risk. And so I think there is some concern, although I completely agree with what Dr. Bushnell just said, some concern as we move PRRT earlier up, that then when we are pulling the trigger for cytotoxic chemotherapy, I shouldn't say the affinitors in this, cytotoxic chemotherapy, is that then changing the risk associated with the chemotherapy?
I think that I always get that hard question about sequencing data because I don't think there's any data. So that is still the problem, and I think it's hard the answer is basically we don't know, I think. So the NETTER-2 data provided the premise for doing what we call upfront PRT, especially like even at diagnosis in some of the what we consider high-risk patients with treatment. The reality in life and practice is many of those patients that did not will get PRT at progression, or what we call crossover. So how is this going to alter the survival? And how do we still conclude what comes early and what comes later makes that change? That's unclear. And I think the second point about toxicity, there are definitely series that look at temozolomide being given first and then PRRT, increasing the risk of myelodysplastic syndromes. And there are equal number of studies that probably have concluded the opposite. So retrospective studies, meaning like things that have looked back at data. So at this point, I think it's probably the hardest question to answer as to when to act with any drug therapy. I mean, I'm not just generalizing that question to PRRT because, do we even act at some point is still unclear some situations. And if we do, what choice of therapy? I think, again, that's why you need all of us debating each other on a panel like this every single time for every patient to say what maybe makes more sense. And there's definitely patient preference. I do agree that whatever Dr. Bushnell gives is better tolerated than what I give, typically. So definitely in terms of tolerance short term. So
I was just going to add, in terms of the data that we've got from the NetPro project to date, we've looked at self-reported treatment sequencing. We haven't got access to the EMR data yet to back it up. But from the self-reported treatment, we see about 7% of patients actually reporting use of PRT at any stage in their therapy. So it's a low proportion overall that actually go on to receive PRT currently, in our cohort anyway. We don't know how representative that is overall. So the more data we can gather from patients, the better we'll be able to answer those questions.
And Michael, your cohort is newly diagnosed.
Newly diagnosed,
so
yeah.
It does.
So we have a chunk of patients with this newly diagnosed who have received a somatostatin analog, and we don't have enough follow-up yet to see when they'll actually move on to receive the PRT.
I was just going to add to say, to make sure the surgeon here is also, at progression, it doesn't mean always PRT. Even in patients who have had PRT and progressed, we sometimes do surgery, and also vice versa, more than one surgery. So some of these options are not once and done. Sometimes they can be repeated, including embolization and other options.
Quick question, specific question. Is there a trial in Omaha for PRRT for a person who's had previous beta PRRT and now wants alpha PRRT? Yes, there is. It's the advanced trial. Who's running it? Dr. Baer, is that it?
I don't know the name of the person.
Yeah, it's not at the university. It's...
Nebraska Cancer Specialist.
Thank you. Yeah, so yes is the answer to that one. Oh, interesting. Are we still considered rare? Yes. We're at risk of losing our rarity. Rare diseases are diseases with less than 200,000 people. Yeah. Data from 2016, 2018 was 171,000 people. So please, people, stop getting this disorder. Was that a time, gentlemen, please? Gentlemen and ladies, please? Was that what that was?
No, she was telling me that my Uber is coming.
Oh, your Uber, sorry. Yeah. Okay, time, Mary, please. Yeah. Okay. There were a number of questions about kidneys. Some of them perhaps in three different handwritings, so it's a big topic here. So you mentioned patients with decreased kidney function. Is there any new or known evidence that supports a link between NETs and CKD? I'll take a piece of that. It doesn't strike me initially as though there is. I guess previous PRTs and indeed current PRT, there is an impact on kidney function going forward. I can't remember with some of the chemotherapies whether there's an impact on kidney function. Somatostatin analogs, it's interesting, and there's another of these kidney questions related to kidney stones. So there's at least one case report of use of long-acting sandostatin, I think it was in this case, and development of a particular type of kidney stone called an oxalate kidney stone, which is a somewhat unusual kidney stone. I am not sure. We've never really looked at our data on kidney stones, and perhaps it's something that we should do. I'm not sure that people have really looked carefully at those data, but other folks are hearing amongst their support group that there are kidney issues. Comments, Dr. Chandrasekaran, maybe?
I can't think of a direct way that I know or explain, but I can think of 1,000 different indirect ways. So I think it's most common thing still in this case is common. So aging-related kidney dysfunction, as we saw Mike's slide about the comorbid conditions, I think hypertension was number one, diabetes number two. So like a vast majority of our patients have other comorbid conditions which are more likely to cause the kidney dysfunction. I think every hit takes a hit, right, ultimately. So if you had carcinoid crisis, bad diarrhea, chronically dehydrated on top of that, that could lead to more problems. So yeah, I don't know about a direct link, but I can think of many different ways like this too.
Right, and then there are issues that come up for my surgical colleagues where there's tethering of ureters in retroper, so the outflow of the kidneys becomes tethered in some of the peritoneal retroperitoneal disease or lymph nodes, which you sometimes end up trying to free those guys up.
I think except for Mike, everybody here is guilty of causing some kidney injury somewhere.
How about just getting a lot of CT scans?
Right. So there may be a number of issues related to kidney. So for Dr. Bushnell, okay, this is a quick one. I might even take it myself. Is it necessary to administer Lutathera by a PICC line? We never use a PICC line.
Very rarely
Yeah.
do we use a PICC line.
Okay.
Only if IV access, if we're really concerned that we might extravasate because the peripheral IVs are so bad, but very rarely.
Right. So a PICC line, for those who don't know what a PICC line is it is an intravenous line, but it's a long line going centrally. I don't
Into
know
the vein.
how close it goes. Do you post PRRT scans? Do you recommend post PRRT scans to measure uptake? So it's a dotatate post PRRT scan, PET scan. Sounds like.
Interestingly, I just saw some data. Most sites do the post-PRT imaging. I'm not entirely sure that as a routine at the present time they have a lot of value. Certainly for selected patients they do. Largely we think that they're most valuable for dosimetric calculations.
Anybody's practice, but I think practice is very variable. I kind of consider getting a post-PRT PET more like a new baseline, I would say, so that if I ever get a PET later on, there's not like 100 new things I'm comparing it to. So I don't know the value of that PET scan, to be honest.
Yeah, I apologize. I mistakenly thought, and you've corrected me here, that I was thinking about, so you can image lutetium. You can take images, you can scan with the lutetium, and so many sites, in fact the majority, as I just mentioned, the majority of sites after they deliver the lutetium treatment are scanning the body to see the distribution of the Lutathera, and we do as well sometimes, but it's, I think probably the question was more about PET. Okay, thank you.
Okay. Continuing on, quick question here. Besides hydration, are there other ways to protect what kidney function is left in light of treatment options? This is where I would involve my nephrology colleague, because it is super important to maintain that kidney function, because if kidney function goes downhill, we are in a bit of a pickle with PRRT. We get problematic with some of the chemotherapies that Dr. Chandrasekharan mentioned. So really important to get a nephrologist involved if the kidney function is going down. And the nephrologist is going to look at diabetes and diabetes control, hypertension, use of ibuprofen and like medications, other kidney issues.
Real quick, I was just, oops, did you turn that off? She's silencing me. It's probably fair. ACE inhibitors are an often overlooked. There was data generated 15 years ago or so, some of it at the University of Iowa, but others, that ACE inhibitors are effective for reducing the diminishing kidney function as a result of radiation to the kidneys, either PRRT or otherwise. So we've thought a little bit about, do we really need to look back at the effectiveness and the possibility of being more proactive with ACE inhibitors.
The other thing, as Dr. House said, is be careful about contrast for CT scan, so I would shift to MRI. It has no effect on the kidney function. So if you have borderline GFR, I would switch to MR exclusively for your follow-up imaging. If you have to use contrast-enhanced imaging. For belly you will, chest you might not, but for your belly imaging I would do an MR.
Great, thank you. Quick question for Dr. Chandrasekharan. Is neuropathy caused by some cancer treatments, and what can be done about it? Not sure that your cancer treatments do it.
So I think some people refer to, I guess, neuropathy defined by us versus the patient may be different. Just so clarify, I always would say what you feel is what you feel. What we define does not count. I think a lot of the chemotherapy drugs, like the capecitabine, may cause hand-foot sensitivity, or even the cabozantinib, sunitinib may cause what we call as palmar-plantar erythrodysesthesia. This is basically the redness and the peeling or the sensitivity that some patients may also refer to as neuropathy, because some people have that linger later. I think the true neuropathy, where there's numbness, tingling, and nerve damage, as we know, is mostly caused by IV chemotherapy drugs that we use typically in high-grade carcinomas, but we sometimes use them in low-grade or grade 1, grade 2, but not very common. And unfortunately, across the board, even in other cancer-related drug therapies, there is nothing that has been shown to prevent neuropathy from a drug treatment.
Right, thank you. Dr. Bushnell, did you say that by altering Lutathera dose, it is it is possible to need fewer treatments. I think you said something about a clinical trial that looks at altering the dosimetry dosing and your goal of lowering number of treatments. Could you just re-comment on that?
Right. So the current Lead-212 trial that we have at the University of Iowa, we only treat with 2 cycles, and that's in part related to the data that I mentioned, where a lot of us have found and measured over the years that the first few cycles are the most effective at delivering the radiation dose to the tumor. And then the other side of that is that the trial that we have is also designed to individualize the patient's amount of radiation to the kidneys, so patients that can tolerate more radiation to the kidney, well, we can give more radiation to the tumor then. But folks that can't tolerate, and we have the dosimetry measures that tell us this, can't tolerate the dose to the kidneys, we will diminish the amount, and so we don't cause kidney toxicity. Is that kind of what we're thinking?
Yep, great, thank you. What are the options for patients with no receptors, no evidence on CT or MRI, but very symptomatic with markers, strongly suggestive of NET? I would be happy to talk to you personally. That's a very difficult clinical problem because it sounds like there's no diagnosis of NET here, so come talk to me. Do hormones in your tumor produce a chemical taste at the back of your throat or in your mouth? Not to my knowledge, but some of the mouth symptoms with Afinitor?
Yeah, I can cause that as a
Thank you.
drugs can.
So that was an affirmative for that?
Well, some drugs that we use can cause that, but not the tumor itself. I don't know about the tumor itself causing the symptoms, but some of the drugs we use definitely can alter taste, mostly temporarily. Once you stop the drug, it gets better.
Great. Dr. Bushnell, by individualizing the dosage on your studies, aren't you introducing a new variable? How will you sort the results out? You'll get a good statistician, won't you?
Well, I think, Dr. Dillon, you've answered it. We have to rely on our good statisticians to sort that out. And by the way, I just wanted to comment, PRRT doesn't cause altered taste. So.
What causes leukemia?
What about surgery?
Sometimes.
All right. Do any of you use the REN test, also known as liquid biopsy blood test? Dr. Chandrika.
I think it's the NET test.
The NET test, yes. The NET test from the REN company, W-R-E-N company.
I'm trying to think how to answer that. Well, I think prospective validation, meaning it has to be tested in large number of patients for anything like that to become a clinical tool in practice, and that information is still lacking at this time. I know there are some ongoing studies. When we say prospective, which is kind of considered gold standard, you don't look back, but you try to look ahead and collect data. And those kind of studies are ongoing, and they've been incorporated in some of the ongoing PRRT studies, the NET test, which is using a combination of some predictive markers. So as of now, no. I don't know if anybody in our clinic uses NET test.
Yeah, I would just say that in NetPro, for example, we're asking patients about somatic and genetic testing, and NET test being one of them. So hopefully maybe put a prevalence estimate to that, so we have an idea of how many patients actually get genetic testing or NET test as well.
And there is circulating tumor DNA, which is a very different concept from NET test. As an oncologist, we use that in a lot of other cancers. I think I've only adopted that in selected patients in neuroendocrine for various reasons. I do tend to do them more often in high-grade carcinoma, like you said.
Okay. A couple of questions that I'm going to take. Are SSA medications useful for patients without carcinoid, I presume without carcinoid syndrome? Does one have to be sensitive to SSA to be useful? Somatostatin analogs are given for 2 reasons. 1, symptom control, carcinoid syndrome. 2, inhibition of tumor growth. So absolutely, somatostatin analogs, very important for people with carcinoid tumor, but without carcinoid syndrome. Does one have to be sensitive to SSA to be useful? One has to have those receptors on the tumor to be activated by somatostatin analogs. Are glucagonomas treated like diabetes? Diabetes is treated like diabetes, whether diabetes is produced by glucagonoma or Cushing's or whatever causes diabetes. There are ways to treat diabetes, and I treat diabetes the same, irrespective of its cause, i.e., whether there's a net aspect to the cause. So there are a lot of other things that we do with glucagonomas which will improve the diabetes as well. Are there any questions from the floor, or do we have any time for questions from the floor?
Yeah, I would say we have time for one more question, if anybody wants to ask questions from the floor. I'm going to go tonight.
I'm just wondering how you detect the chemo-resistant cells, and are there any trials in the process of trying to detect them earlier, and how do you treat them?
Thanks.
I'll probably take that question. I think it's a question for not just neuroendocrine tumor, it's across the board for many cancers. Like whenever we use a treatment option, when they become resistant, what actually happens in the tumor, I think sometimes we know, but oftentimes we don't know. This is where, at least in other cancers, we do serial biopsies and serial things. I think it's probably, I would say, one of those things that we we have very little knowledge, because cancer and chemotherapy, the way it works, the mechanism of growth is not like a simple one-step process. There are thousands of molecules we know, and there are probably millions we don't know, and millions of pathways that crosstalk with each other. So it is probably, not just for neuroendocrine tumor, a question across the world and across the cancer field. A little bit different, though, that is important to discuss is in neuroendocrine tumor specifically, are there tests that can tell us that a certain patient may respond to a certain treatment, like a prediction? Like we have the receptors, octreotide receptors, we think about PRRT. Are there things like that that could be looked into or being looked into for drug therapies? There's definitely some interest in a protein called MGMT, which is tied to loss of that particular protein. Maybe at least in brain tumors, for example, temozolomide works better. Do we have that kind of data to make a broad sweeping conclusion yet in pancreatic neuroendocrine tumor? Not yet, but there's definitely a lot of interest in that area. So it's a broad question. It's very hard to answer because there's just so many factors in carcinogenesis, meaning like the growth of a cancer. Thank you.
Well, also loss of genetic markers like RB and P53. Like that's why a repeat biopsy sometimes would be very helpful to see if it's lost some of the genes that it was expressing before.
Well, I hope everybody got something from today. This has just been so tremendous, and I'd love to just give a great hand for our panel who